Hello, I'm Rachel Babin from Oncology News Australia, proud producers of the Oncology Journal Club podcast. Join Eva Segelov, Craig Underhill and Hans Prenen as they chat through the latest papers. This week, Hans gets stuck into Nature, offering insights into the origins of pancreatic cancer. Craig has an urgent call to raise the bar in oncology, and Eva looks at treatment options for liver-only metastatic colorectal cancer. Quick Bites are as diverse as ever, covering smoking cessation, out-of-pocket medical expenses, and you'll also hear a case report on restless anal syndrome. Yes, only on the OJC. So join us for the most relaxed and amusing oncology podcast. Reach out to us on Twitter using hashtag OJC. As ever, you'll find links to all of the papers, bios, and Twitter handles in the notes on our website. For regular news and podcast updates, subscribe to the Oncology newsletter on oncologynews.com.au. It's free and it's a great way to support the OJC. This is Rachel Babin and this is the Oncology Podcast.
G'day, g'day, g'day. It's episode 53 of the OJC and I'm here with my fantastic co-hosts, Hans Prenen. G'day.
Glad to be here, Eva.
And Craig Underhill.
How are you, everyone?
How are you? We'll go straight into our paper of the week. Hans, what have you got?
Actually, this week I was reading Nature. Sometimes I do this. It's quite painful, but I selected two main papers there and I will try to explain them to you. The first paper is about insights into the origin of pancreatic cancer. It's published in Nature, September 2021. And why is it important? Because the initial event that gives rise to pancreatic cancer is not fully understood. So, as you know, maybe I will recap. There are two main pancreatic cell types. You have the acinar cells that secrete the enzymes, and you have the ductal cells, which line channels to the intestine. And a guy called Neuhofer, he provides key insights into the question which cells give rise to pancreatic cancer and how does it rise. So what did they do? They focused actually on a subset of the acinary cells, so the ones that produce the enzymes, and that express the enzyme telomerase reverse transcriptase. Let's call it TERT. So not third or TERT, it's TERT. T-E-R-T.
What if it's the third TERT?
Yeah. Yeah, let's call it TERT then. Maybe it's easier. So this enzyme enables dividing cells to maintain the length of the telomere. So it's something in the telomere sphere. And what did he discover? That the acinar cells, the one that produce the enzymes, and not the ductal cells, express this TERT. And that these cells had a greater number of precancerous growth. They can easily acquire KRAS mutations and develop cancer. The disadvantage is that this is not testable in humans. You cannot wait until somebody gets cancer and do repeated biopsies to see what happens. Maybe it's important to develop new strategies to intercept early stage of pancreatic cancer tumor formation in, let's say, high-risk individuals. But it's usually, as it is in nature, interesting, but not very applicable yet, and I think not the coming years. The second paper is even more interesting. And it's something that intrigues me already for quite some time. And it's called Tumors Block Protective Muscle and Nerve Signals. So you know that certain cancer cause people to get weak and to waste away, particularly lung, Craig should know this, and GI tumors such as pancreatic cancer. And these patients get into a catabolic state. So there are no approved therapies for cachexia, but still they do a lot of research on this. And a guy called Sartori, he described in Science Translational Medicine, he described a targetable pathway for cancer-associated cachexia. And this might bring us closer to develop a treatment. And why does it happen? It's because to encounter disease and injury, animals have evolved mechanisms that include inflammatory signals, alerting the central nervous system to reduce appetite and food-seeking behavior. So once you have inflammation, you're sick, you stop eat, and you don't want to look for food. And this is actually some kind of adaptation that limits the vulnerability to predators. So everything comes from animal instincts. And I will not go into detail because otherwise it's too complex for Craig to understand, but I will just explain that it has to do something with the protein noggin, which induces muscle wasting. So why is this an important study? I think it's important to study these pathways, and it's especially the BMP pathway, because all these pathways can be targeted now. So if we know which pathways causes this effect on muscle wasting, I think we will see the coming years more and more studies in this field to check whether we can inhibit this muscle wasting or these nerve signals.
It's so interesting, but it's because it's such a fundamental adaptive response. There's probably a lot of redundancy. So targeting one pathway may only be very temporary. But I do think they were very interesting papers, even though you just wanted to get on the radio saying, I read Nature.
Yes. When I grow up, I want to be professor and present a paper for Nature on the Oncology Journal podcast, Eva.
Yeah, my dream came true.
All right. So, Craig, bring us back down to earth. What have you got, man?
I have got a really amazing paper. You would love it. You will just love this, Eva. It's called An Urgent Call to Raise the Bar in Oncology. They basically, this is published in the British Journal of Cancer, and they've done a review of new oncology interventions over a period of time and looked at a number of issues which may confound their approval and led to the approval of what would now be considered low-value oncology treatments, which the authors say with the COVID-19 pandemic enforcing the elimination of low-value interventions in all fields of medicine, all those involved in cancer care need to select only high-value and sustainable interventions. So they did a critical interpretation of clinical trials, looking at relevant outcomes, whether they included patient-reported outcomes, what the survival benefit was. So I'll just give you a couple of examples. So it was a really interesting paper. It plays to the theme that you love and some of our guests have talked about. So here's an example. So clinical trials leading to regulatory drug approvals with a limited overall survival benefit. So in 2021, looking at the time span of the studies were anything from 2010 to 2020, 298 randomized clinical trials for systemic treatment in breast, colorectal, lung cancer, so the top three, published in high-impact journals, 29% had overall survival as a primary endpoint. And in trials with a positive outcome, the median overall survival increase was 3.6 months, with a range of 2.5 to 6.6. Patient-reported outcomes. Between 2011 and 2018, the FDA approved 42 immunotherapy indications, with PROs published in only 47%. Surrogate endpoints, this is a recurring theme. This was analysis in 2021 of studies done between 2010 and 2020. 298 randomized clinical trials of systemic treatment in breast, colorectal, lung cancer, published in the high-impact journals, comparing randomized clinical trials from 1995 to 2004, 2005 to 2009. How many had progression-free survival as an endpoint? None up until 2004. 18% between 2005 and 2009. And between 2010 and 2020, 42% had PFS as the primary endpoint. So a really interesting study. For the sake of time, I won't pick out any more, but they did look at ways that maybe this field could be addressed. They recommended how to raise the bar in the field of oncology, recognition of the limitations of evidence generated in trials leading to oncology drug approvals, increased focus in medical education on a less is more principle, with special attention for communication skills, for accurate disclosure of prognostic information and aiming for the timely institution of palliative care, improvement in clinical trial design, conduct and execution. Journals should avoid bias in publications, clear and palatable reporting abstract conclusions of the primary endpoint, strict limitation of regulatory agency use of expedited approval procedure to true unmet clinical needs, the regulatory agency approval adherence to indications as studied in the pivotal clinical trial, concerted effort to address oncology drug pricing, and a concerted effort to study alternative lower and less frequent dosing schedules, maintaining efficacy for oncology drugs. So you will love reading this, Eva. I was going to do it as a quick bite, but when I was reviewing it last night, I thought, no, I think this needs to be a bit of a longer discussion. So kudos to the authors. Huge job to go through all of those papers. There is 136 references.
Who were the authors?
They were John Schnog, Michael J. Sampson, Rick Gaines, and Ashley Duetz. And they were from Curaçao. So that's Central America. The Netherlands. Shout out to Hans's neighbours. So there you go.
So you know why I'm so excited for that?
Why?
We've done quite a lot on this theme, and I think it's really, really important. But I'm so excited because next week, our OJC Meet series,
yeah,
and I'm recording it with Dr. Nathan Cherney. Now, Nathan Cherney is the sort of face of palliative care for ESMO, and he was the leader of really the ESMO magnitude of clinical benefit scale. He wrote and said, Eva, I love your show and I'd love to do it. He's a Monash University alumnus from Melbourne who now lives in Israel and is a absolute leading academic in cancer, pain and palliative medicine, but also in this, whole area of value-based care and impact. So very exciting OJC Meets. Watch out for it. And, I think we're going to continue to discuss this. This is the beauty of the Journal Club. It's not just presenting one paper after another. It's putting it into this sort of context.
Curaçao, I looked it up.
It's in Brazil.
No, it's not Trinidad and Tobago.
Oh.
But you're speaking about Curaçao.
It's the same as a liqueur, right? Isn't that funny blue stuff, right, that you drink at university?
Don't you go there for holidays, Hans?
Curaçao is in the Caribbean. I have a patient from there and she invites me to go there, but it's quite far flying.
So was it a Dutch colony?
It was a colony, yeah.
Yeah, okay.
From the Netherlands.
There you go. Interesting paper, Eva.
Fantastic. I love it. All right. Well, I'm going to talk to you about another practice-changing trial published in JCO, and this is the Japanese group JCOG, Japanese Clinical Oncology Group, 0603, hepatectomy followed by modified FOLFOX6 versus hepatectomy alone for liver-only metastatic colorectal cancer. A phase 2 or 3, I think they meant and 3, randomized controlled trial. So, and it's got this wonderful editorial by Chris Booth, and I'll refer to the editorial, entitled Perioperative Chemotherapy for Resectable Liver Metastases in Colorectal Cancer. Do we have a blind spot? So first point is it's really hard to do these trials. This was a trial where patients had to have confirmed metastatic colorectal cancer, but they could have an unlimited number of metastatic lesions in the liver as long as they were thought to be resectable. And they got either hepatectomy alone or went on to have 12 cycles of adjuvant FOLFOX6. Primary endpoint of phase 3 was disease-free survival. And between 2007 and 2019, so a very long time, they recruited 300 patients. Now, in the initial phase, they had a lot of toxicity and they had to modify their doses. That was in the phase 2 feasibility run-in, but they then proceeded to the phase 3 and they got reasonable chemotherapy delivery with the modifications. So during the phase 3, they had planned interim analyses, and at the third analysis, at the median follow-up of 53 months, they terminated the trial early because the DFS was significantly longer in patients who got the chemotherapy. So this is now the updated 5-year disease-free survival with an average of 8.5 years of median follow-up. and you had a 5-year disease-free survival of 38.7%, with the 95% CIs being 30.4 to 46.8 for hepatectomy alone, compared to 49.8% with the 95% CIs 41 to 58 for chemotherapy. So hazard ratio 0.67, confidence intervals 0.5 to 0.92, one-sided p-value significant. So lay down Mazare, game over. Well, not quite, because the updated 5-year overall survival was worse with chemotherapy. So 83.1% if you had hepatectomy alone, and 71.2% if you had chemotherapy. Now, statistically, that difference is based on actually a small number of deaths, and it wasn't statistically significant. However, if you look at the forest plot, all the benefit of chemotherapy appears to be in those who did not get adjuvant chemotherapy after resection of their primary colon cancer. And so Chris Booth in his editorial says, we've had a blind spot. We were all sold on EORTC 40983. That was the EPOC study, which actually did not show statistical significance until they did a number of post hoc evaluations and excluded various patients for being ineligible. It wasn't significant on the ITT population. But nevertheless, this editorial says us oncologists rushed to adopt this perioperative approach. Now, they're very concerned about this new finding of the JCOG trial, 13% absolute improvement in DFS at 5 years, but apparently a 14% decrease in overall survival, although not statistically significant. Now, they said, how can this be? It could be that the chemotherapy damages the liver, could be there's an imbalance in post-trial therapies, it could be some sort of selective pressure for chemotherapy resistance in the group that got chemotherapy, or it could be greater toxicity in the chemotherapy arm. And they make the case that it really is likely to be the latter. And so what this argues is we've actually got 2 contemporary RCTs that show no improvement in overall survival, and therefore we should not give peri or post-operative chemotherapy following resectable colorectal liver metastases. So that is very interesting, Hans.
Yeah, you didn't speak about the quality of surgery, because for me this would be the main issue.
Quality of surgery should not affect the fact that people who had chemotherapy after versus did worse, really, unless they were really sick to start with and then they couldn't handle the chemotherapy.
Yeah, unless they die quickly after surgery. If they die 1 month after surgery, then something went wrong with the surgery, of course, and not with the chemo.
2 questions.
Go ahead.
Did they have any conflicts of interest?
Oh, no. Chris never has conflicts of interest.
They had heaps. But do you think now this is practice changing? Do you think that's been the standard of care, right, is to give chemo after the hepatectomy?
Anyone who knows me knows that I have never been a fan of that EORTC trial. I remember it being presented, they just kept hiving off numbers of patients, Nordlinger, until they got a cohort that they could then make significant. And, surgeons love it because they think that chemotherapy is some sort of magical thing that if you give it, it always works. So it's this concept between giving something and it working being not necessarily one following the other. So I think, I'm always worried about doing harm. And here, if you've got a hint that you're doing harm, you're certainly not benefiting overall survival. I think if you've got resectable colorectal liver mets, they should be resected and there should be no chemotherapy. This paper suggests maybe if they never had adjuvant chemotherapy for whatever reason, they're the group to do it in.
And one more question. So in the last episode, I gave an eloquent presentation in AML about picking out prognostic factors and stratifying patients. So are there any clues? Are there certain subtypes that we should still give, positive margins or other biological biomarkers that would push you to giving it? Or now you're just saying nobody should get it?
No, well, those who had not previously received adjuvant chemotherapy, so they were the group on the forest plot in a post hoc analysis. So you'd need to do a randomized trial in that group, which will never be done. This took 13 years to be done. I do think we have to be worried about harm. I do think we have to, educate surgeons that just because you can give chemo doesn't mean it works.
Right. You can give it if they would come back.
There was no benefit in overall survival. And in fact, you may be doing people harm.
Yeah.
So Hans, is that going to change your practice?
Actually, not really. I'm not fully convinced yet.
What, not to give it or to give chemo?
Not to give the chemotherapy. Because I think what most people do is, okay, if it's unresectable, of course, you want to get it resectable. Once it's resectable, I'm a big fan of giving chemo, even in the perioperative setting or maybe in the total neoadjuvant setting. And I look still patient by patient case. So I'm not really convinced that my practice will change after this publication.
Well, you should read the paper again and you should talk to your patients and say you may have a 14% less chance of being alive at the cost of having about the same increase in DFS. It's a very good study and it's the second of two studies that show the same outcome.
So you will change your practice?
I don't often give adjuvant treatment, I have to say. But I recognise that everyone else does almost. So,
but let's say that you never got adjuvant for your primary tumor. So you got colon cancer, you got relapse. Yeah. I usually take that into account. If they never received chemo before and then you do a surgical resection, then you need some kind of chemo there. That's my gut feeling.
Well, that is the subgroup that appeared to benefit. So I think that you could justify it in that case. But, the data is the data and it's hard to cope with data that we don't want to hear or that doesn't fit our practice, isn't it?
And that we don't understand because nobody knows why.
It makes sense. So they're either been fixed or it's going to come back and you can give them chemo then. Anyway, let's
leave that for many more future debates and go on to our short bites. Hans, what have you got?
So my short bite is in the same field. It's also about colorectal cancer liver metastasis, but the ones that are unresectable. And so there's a lot of debate about transarterial radioembolization. And so it's a big hype because it's a bit fancy, it's difficult, it sounds nice. And there was a paper in GCO with an editorial. And in the article that accompanies the editorial, Mulcahy, he found that the addition of transarterial radioembolization to standard second-line chemo, it improved a little bit PFS, but not OS. So this is in line with also the studies we see with radioembolization in first line and even in later lines. So they conclude that the results of this study, it's mirror prior studies of radioembolization in the first line, and therefore systemic therapy without liver-directed therapy remains the standard. And I think it's a debate that is also ongoing in Belgium now. Should we still do radioembolization and in which settings should we do it? And I don't think we have the answer yet.
Yeah, about as many as we should do post-resectable chemotherapy, I think. Rightio, you got any more?
No, because I had quite difficult stuff to read in Nature.
I only selected one this time. Very good. Okay, so Hans, before you go, I do have an amazing paper of the week. I'm going to do it before we get to the other quick bites, because I thought of you reading this. This is a case report in BMC infectious disease, and it's a case report of restless anal syndrome as restless leg syndrome variant after COVID-19. So this was a 77-year-old man who was quite sick with respiratory COVID, and then he recovered and he got antivirals and he got quite a lot of dexamethasone, about 6 milligrams per day. And then he had insomnia, as you've told us we'll get from dexamethasone, and anxiety. And then he began gradually to experience restless, deep anal discomfort, approximately 10 centimetres from the perineal region. I don't know that I could localise anything like that. And the features were observed: an urge to move being essential, worsening with rest, improvement in exercise, and worse in the evening. So they did a colonoscopy. There were some internal hemorrhoids, no other rectal lesions. They had normal deep tendon reflex. I don't know how you do that at the 10 centimetres above. They had no perineal loss of sensation or spinal cord abnormalities, and he didn't have diabetes or any other problem, and there was no family history, but they gave him clonazepam at 1.5 milligrams per day and it got better. So watch out for restless anal syndrome as a variant of restless legs.
Don't you love the Japanese?
I love the Japanese. I'm hanging out to get back to Japan.
I'm so happy you read these papers, Eva.
While you're reading Nature, this is what caught my attention. You read useless things that have no clinical application, and I read these very important articles and bring them to our audience.
Yeah, fully agree.
Fantastic. So, quick bites. Craig.
Well, I've got one while we've still got Hans, because we tussled a little bit over who would present this, but this is not a race around 9 cities in Holland. This is a study of the overall survival benefit with tebentafusp in metastatic uveal melanoma. So this is a terrible type of melanoma, which is often more aggressive, has a predilection to go to the liver, with terrible survival. So this was a study with this new agent, tebentafusp, a bispecific protein consisting of an affinity-enhanced T-cell receptor fused to an anti-CD3 effector that can redirect T-cells to target glycoprotein 100 positive cells. So a phase 3 study with 2-to-1 randomization between tebentafusp with investigators' choice, single-agent pembro, ipi, or dacarbazine. Primary endpoint was overall survival in a phase 3 study, and they showed progression-free and overall survival advantage to tebentafusp, which I presume is now being registered in some countries.
Yeah, no, this is an amazing study. And of course, uveal is quite different to choroidal melanoma, different mutation spectrum, and very treatment refractory. So this is really an example of a very targeted development of a drug for an orphan disease, and will get orphan recognition if it hasn't. I think it already has, actually.
Good on the melanoma doctors again, poster child of rational drug development in solid tumours.
We should get them on to restless anuses, I think.
So is the target in other tumours, do you know, Eva? I couldn't find that in the paper, but, is it going to be something that could be translated into other tumours if that target's there? I wouldn't have thought so.
Well, that's your homework for next time, Craig. So tune in for next episode. I do know the answer, but, if I told you, you'd have to kill me. So I'll go on to my short bites here. Some updated guidelines from ESMO with other European societies looking at gastrointestinal stromal tumours. So mark that, published in Annals of Oncology. Here's a nice one: post-diagnosis smoking cessation and reduced risk for lung cancer progression and mortality, a prospective cohort study. Here's where you can't randomise people to stop smoking or continue. But this is very powerful. During an average of 7 years follow-up, your adjusted median overall survival time was 21.6 months higher if you quit smoking, even after you're diagnosed with metastatic disease, than those who continued smoking. And it didn't matter if you were mild or a moderate or a heavy smoker. And sorry, it did cover both early and metastatic disease. In all of those groups, if you stopped smoking, your outcome was better. And the funding for that was the International Agency for Research on Cancer. What a good project. So really, when we counsel people, when we meet them, we should, instead of being nihilistic, saying, well, you may as well smoke, it's too late, we really should be counselling them to stop smoking. It impacts survival. So I'll flick back to you, and then I've got a final one.
Well, I've got one here. It's a randomised phase 3 trial of prophylactic cranial irradiation with or without hippocampal avoidance for small cell lung cancer. In many centres, this has become the standard of care. So patients getting prophylactic cranial irradiation, the radiation oncologists talk about this hippocampal sparing. So it's basically a phase 3 study which did show that there was no negative impact on time to progression in the brain. So we've always been concerned if you're sparing the hippocampus, the patient's going to relapse in the hippocampus. And so basically this paper has shown that they don't. So it's practice affirming. Again, most centres, I think, in Australia are doing this, and if not, this probably now becomes the standard of care for the small cell lung cancer patients.
Fascinating. Why doesn't it recur there? How come you can leave out these sections of brain and it won't recur?
That's an interesting question, Eva. I might have some more homework.
Yes, you will have more homework.
No, so one of our radiation oncologists has a particular interest in this and introduced the technique in our centre after doing some training in this particular field. So I'm going to ask him.
Ask him, absolutely. Fantastic. All right, well, while we're talking on topic of radiation oncology, I've got an Australian paper published in BMC Cancer in September called Out-of-Pocket Medical Expenses Compared Across 5 Years for patients with one of 5 common cancers in Australia. And this was patients who were in the Kin Sun and Health prospective cohort. So this was sort of a spin-off study, and they looked at almost 2,000 patients diagnosed between the years 2011 and 2015 with breast, lung, colorectal, melanoma or prostate cancer, and they looked at their Medicare claims for out-of-pocket expenses. So patients diagnosed in 2015 spent 70% more out-of-pocket than in 2011, looking at direct medical expenses. So for breast cancer, the mean was $2,500 in 2011, and it had risen to around $6,800 in 2015. And these were mainly on medicines and doctors' attendance.
What was that in the surgical end of the spectrum, or medical oncology, or low intervention?
So
things like the genetic.
It was for medicines and doctor attendances that had gone up so much, but it didn't give any more. That's the problem with these big databases. Sometimes you don't get the nuances, and, it's only a snapshot, but it's quite clever to look at it over time because you've got the same data. There's a lot of interest in financial toxicity. We might even do an OJC special on it. It's something patients really passionate about. Amongst all the other burdens, there is a huge financial burden along with the diagnosis of cancer.
Okay.
All right. Well, look, I'm getting a little bit twitchy and moving a bit on the chair. So I think at this stage I had better go.
Better go and have your clonazepam.
So I'll say goodbye. Thanks, Hans.
Bye, Eva. Bye, Craig. Thanks.
Bye, Craig. Thanks, Rachel. And
see you. Thanks, Eva. Thanks, Rachel. And thanks to all the listeners.
See you later. Bye.
You've been listening to the Oncology Podcast. If you enjoyed today's edition and would like to subscribe, head over to our website, oncologynews.com.au, and sign up to our newsletter. Thanks for listening.